I'm John Harrell, President of Lighthouse Lab Services. I have Cassie Penn, our RCM Client Manager, and Dr. Eric Corti, one of our lab directors and technical consultants that will be joining me to talk through some of the changes and trends that we see coming in 2023 in the toxicology space. I think we're happy to be talking about something besides COVID finally, and so going to be going back to a more steady line of laboratory testing that we were all talking about before this whole pandemic started. And I'm going to start by just giving us a snapshot of where we sit in time, right? And so if you look back to the beginning of 2020, you see where that toxicology volume was. That's that blue line, and this data was provided by Xifen. That's what toxicology volume looked like in COVID. Was not a thought, and there wasn't any testing happening really. You see that toxicology volume dropped 65%, so to 35% of its pre-COVID level that spring, and started to gradually recover, but really has taken until now almost to get back to the level of where it was before COVID. So you see that black line representing COVID testing throughout it, and the blue line being toxicology. So we're just back to, I feel like, where we were at the beginning of 2020, where we've seen COVID volume drop off almost completely, and we've seen toxicology volume return to almost its pre-COVID levels. It's, I think, like 95%. So we do think that there's opportunities for laboratories to provide this. We think it's very valuable testing that needs to be provided, and we do have some headwinds against us in the form of LCD changes. So I'm going to bring in Cassie Penn, our RCM Client Manager, to talk a little bit about one of the proposed LCDs that will affect toxicology billing. So Cassie, I'll turn it over to you.
Okay, thank you. So there are a couple proposed LCDs that are out there from several different MACs. And so I just wanted to talk a little bit about what those are and a little bit of the background to proposed LCDs. That way labs kind of have an idea of how these proposed LCDs come about, and you can kind of follow them, and then you don't get blindsided by them when they become final. So a proposed LCD is truly that. It's a proposed LCD that the MAC is putting out there. They do a public announcement, and then it goes into a comment period, and they do hold an open meeting during that comment period. So when it's in that comment period, labs can go out to the MCD website. There's several different ways you could search out there on their website. You can search by proposed LCDs, final LCDs, by contractors, by state. But you get out there, once you get on your LCD for the MAC you belong to, it'll pop up and it'll say it's in a comment period, and you can click on it and you can put comments about the LCD. So when it is proposed, there's a couple different stages to that proposed LCD. So it's in that comment period for 45 days. And during that comment period, that's when labs can get on there and make comments. At the end of the 45 days, it's going to go to a comments ended status. And during that status, they have to review and respond to every comment that's made. That takes about 3 months. And then they are going to respond to those comments in a response to comments that will be printed on the LCD, the proposed LCD's website. After that period, it goes into an in notice period. So it sits in that for 45 days. If there is not an extension, then it will become final on that 46th day. There are different ways to look and participate in proposed LCDs. There's the Contractor Advisory Committee. That's always an option. I don't know how often they have openings, but health professionals can get on there, be on those committees. And it is really just a way for the MACs to supplement their internal expertise when they're looking at proposed LCDs. They want to try to help it be unbiased and contemporary in consideration. Those meetings are open to the public. So on the websites, it'll be announced when those are. So you can attend those. Sometimes they're in person, sometimes they're online. You can attend those. They allow you to observe portions of it. Obviously, there are some of that meeting that is closed to the public. And then there are open meetings. So the open meetings are really discussion on the rationale behind the proposed LCD. And those, you can listen to those live, or even you can listen to the recordings. And I do suggest listening to those, even if you miss the live one, because it really kind of gives you an idea, the why behind the proposed LCD. And then obviously making comments. That's an area that you can participate and kind of let your idea be known. And then, and just on a broader level, being able to do the advocacy. There's a lot of things out there that affect the lab. And I think John was going to talk a little bit about the VALID Act.
Yes, yeah, thanks, Kathy. So along those lines, bigger than toxicology is this VALID movement that we see happening. VALID's going to be voted on here in the coming weeks. There's very limited time for us to act. If you're not familiar with VALID, that would require laboratory developed tests to come under the jurisdiction of the FDA. It would greatly increase the bureaucracy as well as expense for laboratories to register and get approval to offer laboratory developed tests. Most toxicology confirmation tests, all that I know of actually, would fall in that laboratory developed test bucket. And so I am going to give an opportunity here to push to your screen a chance for you to speak with your local representative. We've made it really easy. If you click through the link there, you put in your address, it'll automatically pre-populate some information there that you can send to a local representative about how the VALID Act affects laboratories, and it'll automatically find the representatives and address it to them based on your address, right? So you can do it in about 30 seconds. I encourage you guys to do that if that's something you care about. I think it's important for our industry that we continue to be able to offer laboratory developed tests quickly. As an example, as we're trying to come up with new methods to test for street drugs, you need to be able to do that quickly to respond to what's happening out there on the street, and it's very difficult to do that if that becomes heavily bureaucratic and takes a long time. So quick plug for VALID, and then I'll turn it back over to you, Kathy.
Thank you. So we're looking at, okay, so the current final LCDs for urine drug testing. All MACs except for NGS allow for G0482 and G0483 if medical necessity is met. NGS was the first MAC to come out with a proposed LCD eliminating G0482 and G0483, and their final LCD just went into effect the 1st of October. And basically what they're saying is that they are not billable and they will only recognize up to 12 drugs. Now, Noridian, that's one that I'm watching. They do not have a proposed LCD eliminating G0482 and 83. And I'm watching that because usually all the MACs kind of take suit as these proposed LCDs are out there. So we see First Coast, Novitas, CGS, Palmetto, and WPS. Currently, they do allow for those two codes, but with the new proposed LCDs, they are stating that they are not medically necessary. And so that'll have an effect on labs, especially if you have a high Medicare population and you are doing those higher codes. So that's a major change for laboratories. And then the other thing that I really noticed that was pretty common through the LCDs is documentation requirements. And really what it's stating is they want to see the clinician's rationale for the definitive testing documented in the medical record, and they want it individualized based on that clinical history and risk assessment, and they want it documented. So what does that mean for labs? As I look at it, we may see an increase in denials that are requesting medical records, and then labs, would have to submit those medical records and ensure that documentation is in there. Now, that's not a guarantee. I noticed that was a very strong comment throughout all the LCDs, and so that might be an issue as this LCD does become a final LCD. And as we look at this, really what these LCDs are trying to push is they want providers to really look at the purpose of the urine drug test and make sure that they're ordering the presumptive and the definitive in the basis of the patient. And they've got a list of things in here that would um, constitute meeting medical necessity. And so it's just good for labs to kind of have these in mind so that they can really help set clinical protocols with the physicians so that they are ordering when it's reasonable and necessary. And then same thing for limitations. They really want the drug testing to be individualized per patient. So we know that they don't like blanket orders. They don't like standing orders if it's not specific to the patient. If you have any reflex testing set up, it's important that you have that reflex order documented showing why the physician wants it reflexed. Some of the typical things that we know they won't cover, you can't do more than one presumptive or more than one definitive in the same day. That'll deny. They don't like to cover drug screens. So if you do testing on blood and urine, one will get denied because they won't cover it. They just really want that physician to prove that these orders are for specific to that patient. And really it has to do with that it's affecting that patient management. Some other things that they don't like to cover, obviously they don't cover medical or legal drug screens or employment purposes. If anything has to do with physician from drug diversions, they won't cover it. So the limitations and the purpose of the drug screens is just a good basis to set for clinical protocols for ordering for physicians. It kind of gives them a good basis on when they should be ordering, and it kind of gives them a guideline. And I am going to turn it over to Eric now.
And actually, I'll jump in real quick to intro Eric, Dr. Corte. He's going to talk to us about the lab's role in the opioid epidemic, but I thought it'd be good to just know where we're at in time on that as well. So I've got a graph from the CDC here showing 3 waves of opioid overdose death. There's been 500,000 deaths since the 1999, so about the last 20 years. And we've seen that come through in 3 different waves, with the first wave starting in the 90s and having a consistent increase since about 1993. And that's been in along with the prescription increase, right? So we've seen greater number of prescriptions for pain medicines being written, and then we've seen opioid deaths track with that. Wave number 2 happened more in around 2010 and was a wave of heroin abuse and use that we see there kick up. And then the third wave, starting in more 2013, was a fentanyl increase. And you see that being a very drastic ramp there. And Dr. Corte is going to talk to us a little bit more about that. But obviously, opioid epidemic still very real, still a major issue in our country. Laboratory testing is a big part of the solution to that. And so it's important to make sure that we're advocating for testing and the role that it plays. So Dr. Corte, I'll go ahead and I'll turn it over to you.
All right. Thank you very much, John. All right, so how does the lab respond to the opioid epidemic? Obviously, we need to be testing for fentanyl. Even after a brief disruption of supply due to the COVID shutdowns, provisional numbers from the last 12 months, between April 2021 and April of this year, look even worse than they did in 2020, with approximately 2/3 of an estimated 108,000 overdose deaths in the United States involving synthetic opioids. Fentanyl is going to be present because it just makes sense to dealers and chemists. It's more concentrated. They don't need to they can traffic small amounts in smaller containers, and they can cut their supply further to serve their population of users. As laboratorians, do we need to test for all this? Start out with a little paper that just came out in up to the month in
Eric, it seems like we might be having an issue with your phone connection. I think I'm losing you a little bit on our end. John, are you able to hear him okay?
Yeah, I agree. I was having a little bit of a hard time hearing Eric, so I don't know if there's anything you can do to strengthen your connection.
Can you hear me well?
Yeah, we hear you there. That sounds good.
Okay. I apologize for that. So very briefly, even though we did have a little opioid death earlier on in the pandemic, fortunately, as open supply of manufacturing, those have actually significant in
Eric, maybe we could pause for a minute and try to switch over back to your computer audio. I apologize, but we're getting multiple comments that the audience can't hear you right now.
We're still having a hard time there.
Okay, I will.
And then while he's switching, I will tell you the only interesting fact I know about that to buy time. I heard from Dr. Corti yesterday that a gallon of milk size of fentanyl could kill over 1 million people as an overdose. So just the amount of fentanyl they could fit inside of a gallon of milk. So as he was talking about, it certainly makes it easier for dealers and people trying to do illicit things with it to transport it, because you need a much smaller quantity than you did with most drugs historically. So that's certainly part of the danger there, and why we see the increase of use and prevalence of it out on the street.
All right.
All right. Is everybody able to hear me a little bit better now?
Yes, absolutely. Thank you.
Okay. I'm sorry for the technical issues there. So again, very brief recap here. Numbers have significantly gone up as the pandemic has waned somewhat and supply of opiates have come back. We have seen numbers that far surpass what occurred in 2020. So between April 2021 and April of this year, of the 108,000 deaths, 2/3 involve synthetic opioids. So there is a problem. And how do laboratories respond? So do you need to be chasing all of these fentanyl analogs, the synthetic opiate analogs? This is a great little paper from Morbidity and Mortality Weekly Report from just a couple of weeks ago, looking at parafluorofentanyl between fall of 2020 and summer of 2021. And as you can see, the deaths associated with parafluorofentanyl went up significantly. But something for most labs to note is that the little line at the top is showing that the number that co-involved with illicitly manufactured fentanyl itself, the parent drug, encapsulates almost the entire population. In the majority of these cases, you're going to see fentanyl in addition to something else. So the question is just testing fentanyl good enough for your patient population? Now, to highlight the issues that can come from chasing some of these of analogs, here's an example from the last couple of years where isotonazine hit in the middle of the country in Kentucky, Ohio, Indiana, and Illinois in the summer of 2019. It's still around now, but it's nothing like it was in the summer of 2019. It was the drug of choice in the region for many months. It lasted about 8 to 10 months. And then a little less than a year later, metnizine hit in early summer of 2020. It lasted a little less, about half a year, and then butanizine hit. And these are just very minor modifications to a side chain, but they change the weight of the compound. They change the way that it's going to migrate down the column. So you're not actually going to be able to identify these. But in every single one of these cases, the majority of the patients also tested positive for fentanyl. So the question is, as laboratorians, how do we respond to the opioid epidemic? We do it deliberately. We do it with purpose. We make sure that if we are looking for a specific target, that we have a reason to look for that specific target. If you're a forensic lab, or if you serve a major trauma center, or if you have a high population of cancer patients, if you serve oncology centers, maybe you do need to be looking at some of these analogs because you're going to have patients that are on fentanyl or that may have other drugs on board, and you actually need to differentiate. The vast majority of treatment centers and addiction centers, you may be able to serve your patient population and your providers sufficiently just by identifying fentanyl. So it's easy in the laboratory to feel isolated, but remember that you're part of the medical community and we provide a service. So take your time and get the advice you need before making decisions that are going to consume your time and resources. So make sure that your efforts are going in a direction that both serves your patient population and your providers properly. So there are a lot of great resources out there. Obviously, the CDC's gold mine of data. The data tend to be slower to arrive, but the data are very well groomed by the time they do arrive. And as of February of this year, their provisional overdose data will be coming out in 4 months rather than in a 6-month delay. CFSRE, the Center for Forensic Science and Research Foundation, is a spectacular resource, very different than the CDC. So what they do is they find a new drug. They say, we just found this new drug. This is the characteristics of it. This is where we found it. This is the body type, body area that we found at the matrix. And these are the characteristics of the compound. They show it, they say this is what it is, and then they move on. So you have an idea that it exists, that it's in the area. They're not going to give you the huge data sets that the CDC gives you, but they will give it to you very quickly. So they're a great place to review, at the beginning of each month. Now, don't forget your local hospitals, emergency room, police, poison control, and patients. You're serving normally the population in your area. Large reference labs can pull in from other areas, but smaller labs, you're going to see your patients are going to be going into emergency rooms. So talk to the emergency room, make friends with the doctors, talk to the police department. Poison control is a great resource. And if you have direct patient contact, talk to your patients, ask them what their friends that maybe users are using, where they're getting it, what it looks like, what they're being told that it is. You have a lot of resources at your disposal. Lighthouse is a resource. So we have a huge network of labs that may be seeing the same thing that you're seeing. So please use this as a resource. And something that people often neglect is make use of your screening data. You get 2 shots at every sample using different methods because of your screening data. So take advantage of that. Know your methods. Know what your screens will identify. Know the cross-reactivity of your fentanyl screen. So if you start seeing positive screens, but then a negative confirmation, that could be a sign that you have something new in the area. Now, if you see one of those, you can have false positives. We all know you false positives from high levels of methamphetamine and different targets. So it's easy to go down a rabbit hole. This is more looking at general trends. Over the course of several weeks, if you see a lot of positive screens that don't confirm, that might be something worth looking into. So screens can be a very valuable resource. So talk to lots of places, talk to lots of people, use all the sources at your disposal. If you decide that your patient population, your providers, would benefit by adding a new target, modifying your assay, please, this is where we can step in and help. So novel assay development or modifying a current assay. If you need to find control material or proficiency testing or split sample testing, we can connect you with other laboratories to do split sample testing or alternative PT. We can help you find the control material, everything down to actually modifying and optimizing the assay itself. So please use us as a resource as well. We're all in this together. We're trying to serve the same patient population. So use everything at your disposal because we do an important job at the laboratory community.
Yeah,
all right, I'm going to turn back over to John.
Appreciate that. Some great stuff there. Yes, please reach out to us at Lighthouse if we can help as well. There's a couple handouts on the right side. If you need any of those services, remote data review, we do that 7 days a week. If you need some assistance looking at peaks, we've got teams of qualified people to do that. Need help creating a new method, validating it. Alternative PT, we've created a list of common analytes that are not covered by CAPS PT program. So if you're interested in that, let us know. But we're here to help, and we will go ahead and go into some questions at this time. So we'll see if we can do our best to answer some of those. If you have questions, please feel free to drop them in the Q&A section. So we've got a question from Sam, and he's saying, this one looks like it'd be for you, Cassie. Is there an estimate of how much money the government will save from these LCDs? Or said another way, is there an estimate on how much this will reduce the government spend on testing? That's a big one. I don't know if we have the answer to that. Cassie, let me know if you think that we do, but I have not seen numbers. I know I've seen some PAMA numbers and what they're trying to save with some of those cuts, but I'm not sure if anybody's seen specific numbers tied to this LCD.
I have not seen specific numbers.
Okay. Sorry, Sam. If you find out, let us know. We'll spread it around. Sherry wants to know, do most payers allow reflexing to the confirmation based off of the laboratory presumptive test performed? I think that, go ahead.
I was just going to state, I think each payer is just a little bit different on what they're going to allow. But if you do any reflexing, it does still have to be patient specific. So I think that is hard to drill down if you're just going to do that reflexing off that presumptive test.
Yep. And then you had mentioned earlier, Cassie, that you can listen to comment periods from previous LCDs, open sessions. Do we have a link to that or any guidance on where those could be found?
Yeah, I can. Yeah, I can. I've got a link. It's out on the LCD site, but I can send the link out.
Okay, that's great. What other questions we got here? These new analogs are ever changing. How can we ensure that we're capturing those and differentiating? This one would be for you, Dr. Corti. I think you covered this a little bit, but do you want to comment any further on how to capture and whether it's worth capturing the continuously changing analogs?
Yeah, that's a great question. And the answer is we're not going to capture every single ever-changing analog because they could change over the course of a weekend. You can have a chemist who manufactures something with the pH or the temperature slightly different, and it changes the compound that they produce. So the question is it worth capturing every single analog? If you're in forensics, obviously, yes, you need to capture everything. That's a whole other conversation. But in the laboratory, in the clinic, if you're talking about pain centers, the majority of these illicit fentanyls, illicit synthetics that are produced are going to have a mixture. They're not going to be a pure analog. They don't have the manufacturing capability to produce that. And so you're going to end up having parent fentanyl in it. Therefore, if you're trying to intervene in the patient's care, if you're trying to intervene in their recovery process and get them back on the right path, identifying fentanyl in most cases will be sufficient. Unless you're in a unique situation where you have a high rate of fentanyl prescriptions in your population, normal identifying fentanyl is enough to say, yes, this patient is using illicitly, this is not conforming with their prescription list, and so we need to intervene. We need something more for this patient. So normally that would be sufficient, because unless you are a major facility that is going to be doing forensic testing and needs to stay up on every single new analog that's produced, it just is not feasible within a typical laboratory.
Thanks, Dr. Corti. Hopefully that answers your question, Sherry. And then last one, we got one from Jason here saying, what are the odds that the private payers are going to follow the cuts for the 0, 4, 8, 2, and 3 that the MACs are doing? And I don't know that anyone has the answer to that, but I think if we look historically that when we've seen reimbursement cuts happen in the MACs, we have seen private payers follow pretty frequently. And so as those restrictions for medical necessity tighten, I would not be surprised to see private payers follow that. Cassie, do you have any other thoughts or comments on that?
Yeah, we do see that if you go out and look at the private payers policy, there are already restrictions out there on the larger panels. Every payer is just a little bit different, but as these proposed LCDs are out there, I think we might see more payers relooking at their drug screen policies.
Well, thank you guys. I think we are probably seeing some price compression. I think it's going to be important to make sure that your labs are running efficiently and finding cost savings whenever you can. Let us know again if we can be a part of that. We produce standards controls and would be happy to talk to you about those if we can save you a little bit of money there. But we're here to help, and I think it's going to take all of us working together to raise the awareness of the importance of testing and the drug testing in particular. Also, please reach out to your representatives on valid it's going to be something that affects us all as an industry as well. So thank you guys for attending and spending your lunch hour with us. We'll get more information out on our next webinar soon, and have a great day.